Good morning. My name is Dr. Singh Rashid. Welcome to today's ECG conference. We are presenting from Severance Cardiovascular Hospital. And let's begin. This is our ECG today. Please share your thoughts.
You can designate first reader. Who wants?
We can go with
Dr. Zhang? Okay. One of
because he's in device.
Also, we can see blink on V2. So, I mean, but on V1 and V2, V3 is negative. So, we can see with the pacing rhythm. So, but PR interval is not that regular. Which means, I think there's a possibility of the sensing failure, I guess. So,
also PP interval. The B1 or B2 of PP interval. Okay, 5 second rule. Minjong?
Okay, I can see the pacing before the QRS complex and the LVP before the maybe is located at the RE. And when you see the V1 or V2, there is P wave notching. It's about 300. So underlying flutter with the V pacing.
Okay. Underlying atrial flutter
Yeah.
with B pacing.
Yeah.
Seong, where does this pacemaker pace? Location and type? What else? We can get information.
What mode of pacing?
well, first of all, V1 is negative, so I think it is a conventional pacemaker rather than the conduction system pacing. And if we think this P wave conducted to this
Can you follow the mouth?
this pacing, it will be a little short. So I guess this P wave was sensed and this was paced. And I think this is also sensing and pacing. So I think the mode is the asensing and repacing mode.
And then the PR interval is changing. Here it's now. Here it's different. Here it's different.
Do you believe it's the ACES repacing?
VV, yeah.
VVIR. Seong, which mode do you suspect?
Yeah, I think the PR interval is changing, but I think the changing is not that high.
So this PR is in
That is
non-physiological.
definitely
They're not
different. Yeah.
If it is the
Yeah.
ACES repacing, the repacing rate should be 300, right?
That's right. So
Can it be DDI?
I think the VVI pacing.
Okay. And so underlying rhythm is atrial flutter. We don't know before the checking the chest X-ray, but it could be the fast atrial rhythm switch mode to VVIR.
But if there's a mode switch, it usually happens at a higher rate. The ventricular rate is slow. So cannot be mode switch.
What? Say again?
Mode switch happens usually we keep it at 130 usually.
Mm-hmm.
So the ventricular rate should be 130
Too
at
slow,
mode.
you mean?
Yeah, yes. So it's actually VVI. And there's an atrial, what's the atrial rhythm?
She already told atrial flutter.
Oh, flutter.
Mm.
So
And then where does it pace? Ventricle.
uh,
장원, Dr. Jang. One more chance.
are because on V1 on V2 V3 is negative,
Mm.
so RV I think V is located in RV, but the QRS is about 120, I guess. It looks much narrower than I think. So
But if you look at lead one, it's almost 200,
I think
but not that wide, right?
yes. So it is close to I'm not sure.
Anything else?
what do you think about the atrial rhythm? Is it typical, atypical? Will you take this patient for typical flutter ablation or how would you plan? Will you do ablation?
How do you think?
Typical.
So let's the interpret one by one. Because the QRS width is not that wide, so probably the septum, RB septum PC, and the axis is the north-east axis, right?
Mm.
So RB middle septum or apical septum side piece. Then let's interpret the P wave morphology. What should I ask? It is typical flutter or atypical flutter? 인정?
And we see the P-wave folds in the V1 and V3 like that.
It will take time. What do you suspect?
I thought it is the just typical atrial flutter
What evidence?
because the P-wave polarity in the V1 and 2-3 ABF negative and V1 positive, so I thought it is a typical atrial flutter.
Okay. Anybody vote to atypical flutter? Leo? Canard?
Well, I also think the with two there is the down slope and the up slope of the P wave. So I also thought it was a typical A-flutter.
Yeah, the rate is a little fast, almost 300, but the polarity of PA morphology is matching to the typical flutter, more likely typical flutter.
So I'll help you. We decrease the VVI rate to 30 and this is what we got. So it's on the sensing now. So what's your diagnosis now and how will you approach, how do you plan your ablation?
Okay. Dr. Yang, we have only 3 fellows, excluding the presenter. You have more chance to speak your
I didn't.
opinion.
What is the background of this decision? What did you say?
Turn
We
off
made,
pacemaker.
a diagnosis of typical flutter.
VVI
You still
PBA.
So we started to use
PBA, sorry?
we decrease the rate to VVI
PBA, sorry.
and sorry sensing.
PBA.
So the P wave from unmasked. Now you can see the P wave morphology and it will more clearly. What will how will you plan the ablation?
Number 1, ovulation of the A flutter. Number 2,
Do you still think it's typical atrial flutter?
what?
Do you still think it is typical atrial flutter?
A flutter.
don't understand what evidence do you have us then. Number one, ablation.
I think it is a flutter.
Typical flutter.
Yes.
And
And A to reconduction is about 7 to 1, I guess. So
you know,
Oh. But first of all, as far as I know, the typical and atypical is the post-op diagnosis. So, I'm not sure about what's your intention. I think
I
that
mean,
like
you see this ECG and you think about ablation, and how will you plan the ablation? Will you plan for a typical flutter ablation, or will you prepare 3D and order 3D? And because in severance, everything is, you can get everything, but in resource poor countries, you have to plan your ablation from, and you have to anticipate what hardware you're going to use. In some labs,
we have the same issue.
in some labs, 3D is not available. So you have to call the 3D person if you feel you need 3D. And if you feel you can do it on only fluoro, then you will not call him. So how will you go about it? Do you think
Yeah, washing, I think washing is a very important issue. It's clinically, if it is CTI dependent flutter, you can just ablate. This is a one-hour procedure. The patient, you can send the patient to back home same day. But if it is atypical flutter, you need the 3D, PBI, more, and pre-operative anticoagulation is mandatory. So you have to think about the clinical decision. So whether it's a CTI dependent flutter or atypical flutter, it's a very important issue clinical. Okay, Linja, how do you think?
So I'm still thinking of the typical hatred flutter.
Yeah, but the based on my experience, I saw that this similar ECG in patient with atypical flutter quite common. And as I mentioned, the FF interval is too short comparing to the typical flutter. So I would like to check the echo or chest PA and the previous history. And I think the atrial size or the combined structural heart disease is helpful to make decision.
Exactly. So the point is that when we consult this patient and we have to plan an ablation, sometimes patient is not insured, and we have to tell them how much it costs, and the cost will depend whether you are doing a typical flutter ablation or atypical with 3D. Some labs do not have 3D, and you have to call the person for 3D. And what will you tell the patient? How much it will cost, and what we are going to do? Or will you tell them, I'm not sure, it's on table. So these are practical issues which come up when you're sitting in the OPD and patient comes with this kind of ECG. So let me give you some more. So we went into the patient history, and let us see if you change your what will be. So she's a 53-year-old female. She had undergone the VSD patch repair in 1984, long way back. Then she was implanted an epicardial VVI pacemaker for complete AV block in 1987, and she has gotten the same year a PDA ligation also. She was shifted, from epicardial to transvenous DED pacemaker in 1994. Since then, she has undergone 3 generator changes, and this is the latest echo. So she has a VSD patch repair. There's a tiny residual VSD shunt flow. There's an enlarged RART with reduced cardiac systolic function. LALV is normal in size and function. There are elevated filling pressures and mild pulmonary hypertension, mild MR, and mild ER. So after this clinical history and imaging, how will you plan this ablation? Do you still think of a typical flutter which you will do on fluoro only, or what will you do?
In my practice, before deciding the CT ablation piece looks like a typical flutter, I always check the Holter first. And some patient shows a combined atrial fibrillation and carefully watching the FF interval. It is too fast, it's more likely atypical flutter, especially patient with structural heart disease and the enlarged atrium. I mentioned the electrophysiology many times. If the patient has significantly remodeled atrium with a high scar burden, wavelet cannot break up. So if you see the patient with mitral AFib, many patients shows the atrial tachycardia-like rhythm rather than the completely disorganized atrial fibrillation rhythm. Because those patients because high scar burden, the atrial critical mass is small. So that's why the atrial fibrillation rhythm cannot break up. So it is very organized atrial fibrillation or atrial tachycardia. So I would like to check the Holter first. And this patient has why she underwent the VSD correction operation when she was very young, right?
Yes.
But the why still there's hemodynamically stressful and the atrium is big. Is there any cause? Usually after correction of VSD, many people is completely normal, enjoy the normal life.
Yes.
Yeah. It is because of continuous BPC or possible. Yes.
So this picture was taken for typical atrial flutter, typical atrial flutter, and ablation was done under fluoro. But when we completed the CTI ablation line, the flutter continued, and EGM atrial activation sequence only changed, but the tachycardia continued. It did not break. At that point of time, we shifted to 3D. So
I think you should prepare 3D because she has a very young age, the VSD operation history, probably incisional scar-related atrial tachycardia.
So VSD is usually repaired through an atriotomy approach. The surgeon makes the incision in the atria and then repairs the VSD, the tricuspid and valve orifice. So that was not taken into consideration, and had it not been in Severance, it would have been an ablation failure in other parts of the world. Then we would have to tell the patient it was a failure, and we would have to call her again for a second session for 3D. But here we have everything. So in the middle of the procedure, we shifted to CARTO and did the activation map, and this is what it revealed.
So two procedures.
Yeah.
Just a single procedure?
Single procedure.
Single procedure. Okay.
So there was an anterior anterolateral atriotomy scar around which there was a re-entry taking place. The important point is that when we did the entrainment initially, the CTA entrainment was perfect. We thought that it's typical because this circuit again, if we entrain here, it'll be in circuit. You will get a small PPI-TCL. So again, entrainment will not help. This is one instance where 3D really helps to uncover the, and you cannot rely on only 2D at this, or entrainment maneuvers. This is one rare instance where entrainment, downfall of entrainment, cons of entrainment, pitfall of entrainment. So such rhythms can fool you on ECG, such rhythms can fool you on entrainment also. And in this coherent video, I want to point out one more thing is that, so we made the CTI block here, but the rhythm, the re-entry continued around this atriotomy scar in an anti-clockwise fashion, giving rise to the ECG pattern. I want to point out one more thing. This is the RAO. Now we are going to the posterior part, and this is the crista terminalis region. Here we can visualize anisotropy in action.
Yeah.
So you can see that in this part of the crista terminalis, lower part, there is conduction slowing. This is a very important aspect of maintenance in the pathogenesis of macro right atrial tachycardias, because conduction around the crista terminalis in the longitudinal direction is faster than in the transverse direction, and we can clearly visualize it on this coherent video where the vectors are becoming thicker and shorter, and there's conduction slowing here. So again, from this is a I thought this is important to point out in this, that we can see the anisotropy in action here, and sometimes there are breaks in this functional barrier. So the crista terminalis acts as a functional barrier, separating the anterolateral wall from the posterolateral wall. So the ECG morphology is determined by how the conduction occurs on the anterolateral wall and the septal side. And so the point is that the point I want to make in this presentation is that ECG of a typical flutter, though it is mostly found in typical anti-clockwise and clockwise flutter, but atriotomy or patch macrorenal tachycardia or non-CTI dependent macrorenal tachycardia without atriotomy can also have sometimes typical ECG flutter patterns. And the width of these triangles determines how what is the probability of a typical. So in RA, the most typical flutter have ECG typical flutter, but atriotomy patch may have this, and non-CTI dependent lesser. Whereas in LA, it's very uncommon, but though even then we can have sometimes it can go into this zone of typical ECG flutter pattern. And lastly, I want to just revise how why we get this kind of a sort of appearance in typical flutter. So there are three regions which give rise to the genesis of these sort of P waves in typical flutter. One is the anterolateral wall, then is the septal activation, and then is the CTI. The CTI is the slowest. Again, there are overlapping muscle bundles and anisotropy, and causes slowing of conduction in the tricuspid isthmus. So the green part of the green part is the slowest, and it's the in counterclockwise flutter, it is the down slope which is very has a shallow slope. Then is the septal activation, because the muscle is less there, so it is quick, and then over the anterolateral wall, it then begins to drop. So it is this portion, the green portion, the CTI dependent portion, that determines the ECG morphology, where and typical flutter is defined by a slow downslope and a rapid upslope across the CTI, and this gives rise to the typical ECG flutter. So the takeaway message from this presentation is that the history and clinical examination is important. If there's a history of atriotomy, we should always consider atypical flutter, even if the PCE is suggestive of a typical flutter, and we should prepare accordingly with the three in mind. And this was the ECG post observation. Thank you.
Washim, can you hear me?
Yes.
Oh, Dr. Wang is here. Oh. Good morning, Dr. Wang.
Good morning.
You are in
So,
Yeah.
Tanzania, I'm on 1:30 in the morning here. Listen,
Oh
can
my God.
can you point out in your chart map where's your crystal terminologies?
Cartoman.
Go to the map. Where's the crystal?
Okay.
This is an important issue. Okay,
And what?
show me where's the crystal.
This,
No, that's wrong.
Middle lateral.
Rotate crystal more anterolateral. Rotate back. No, the other way. Come back. No. Crystal is go to other view or lateral view. I'll show you. Okay. Just keep going. No, right there. Leave their picture. Yeah, hold it there. So crystal is an important structure, as you mentioned. And then when you do atriotomy, all the day atrial surgery, we call venous sinus of crystal. Your scar that you form going to be bounded by the crystal terminalis anteriorly. Scar going to be posterior most of the time. Where you're pointing is a cabo line, lateral wall. This is where you see anterior appendage bulging in the top, all the draw line to IBC. That is most likely crystal terminalis is. Okay? If you go back look at the anatomy book, it will tell you crista is the origin of a pectineal muscle to the trapezius valve annulus. Remember that? So this bulging part is a crista. So it's important to recognize where the crista in 3D map. It's not possible to do good 3D map without looking anatomy. Okay? Second thing, if you go to the first clinical ECG you had, go to the presentation ECG. You did a wonderful presentation, atrial flutter, but there's something that you're missing. Look at this is a pace rhythm, regularly. I don't think it's sensing anything. It's VVI pacing programming. Dr. Park mentioned subtle pacing. But take a look at if you say that, wow, this flutter wave is a little bit discoordinated with the pacing, which makes sense. You will see that all the time in pacemaker, VVI pacemaker, because they're all sensing, okay? Now, you go back to the next ECG. What the next, yeah, here. Here, you're not pacing. I'm assuming, unless patient in complete heart block, which is doubtful because your QRS is narrowish. So some of these atrial activities are conducting and capturing. Look at your preceding flutter wave with relationship to that QRS. It's changing. You see that? That never happened atrial flutter, typical. So first criteria to be flutter, mathematically, as I talked to this before, has to be very regular. In other words, just look at the flutter wave before the QRS complex. Each QRS complex should be all same. This is not. So this is already atypical flutter. Question is, your flutter wave is close to the typical flutter. That's why you wrote this ECG. Very wonderfully done. And because of, as you said, right atriotomy scar tissue flutter looks like this. They looks like a flutter. That is not flutter because there's a lower loop reentry component to it. As that's what you're trying to say to us. And I think it's a wonderful example of the teaching case. Okay? And typically, if you look at the atriotomy scar, congenital heart disease, atrial flutter, whether you atrial right atrial issue involved or not, in practical sense, many EP guys, they just ablate the right atriotomy flutter first, typical, just cut it, even during the, doesn't no matter what it is, because if you leave that right atriotomy flutter plus typical flutter, your chance of coming back with the atypical flutter is 70% in our experience. So you do have to ablate both, regardless. So that's how we do practical sense in the community. In US, if you ask the congenital centers, they first ablate atrial flutter, 70%. And then they go after map to create a better map because otherwise you see that kind of fusion you see earlier. Second, entrainment doesn't tell you too much about what you do, not to do. Yeah, that's a key point here. Okay? Good job. It's a beautiful case. Wonderful.
Dr. Wang, do you believe
Yes.
the cable tricuspid isthmus ablation is mandatory in this patient?
No. We had another case. I just give you an example. When I give ERC, I'll show you this case. We had a case in the Seoul. We patient who had a pseudo reentrant atriotomy scar case where I haven't seen it in a long time, but I was a fellowship we saw. What it is, scar is attached Some of the scars are not homogeneous, and they came from what we call automaticity, local micro reentry. When you map not carefully, they see looks like a figure eight reentry in lateral wall. But when you see it, you map it carefully, the focus actually very discrete small gap. And you don't need to do, I think this current mapping data we have, especially, all this multi-electrode mapping, and then also vector mapping and so on. We can actually separate out from the this sky area, gap area, micro reentry, macro reentry. So I think the pattern is approximately changing now. So we'll discuss that in ERC a little bit. I think you guys get to see the case. Okay.
Well, we
So I don't believe
discussed
we
this.
need to.
Yeah, we discussed
Not-
this issue a long time ago, and at
Right.
the time, the CTI ablation should be done first, then 3D map, and
Right.
data mapping, so additional ablation. But you mean
Right.
nowadays the high density map improves the ablation outcome? So before
Right.
CTI ablation, it's is it fine to map the sky area and the atypical flutter ablation alone is good enough?
Yes. The reason is that the counterpart of that story is that if we try to do cover line, many times your anatomic selection is not proper, then you end up causing 600 syndrome on patient because you have to cut all the way to superior vena cava. That can involve number one, sinus node artery. Number two, sinus node exit site involvement. Number three, you can actually direct ablate the residual sinus node tissue. That creates a problem. Second, as you know, sinus node is not an only cranial exit. When you have a bradycardia, normal sinus node 10 exit out mid-crista area, and you also affecting that area. So there's a many reasons. I think we should do more precise high density mapping, try to only target the scar tissue rather than trying to do just empirical cover line. Unfortunately, third world countries, they don't benefit from such technology yet. But I hope that we can come up some better strategies of like this in the future. Okay.
Is this enough to connect the scar tissue to the inferior vena cava, or we should do a cavo line,
Oh, it's too long.
or should we do a
No.
scar
Yes.
plus or scar
Yeah.
to scale line? What is the best?
Best
So-
option is that we do, I would say my experience, less complication is a longer scar tissue to the inferior vena cava. That's much easier. Second is that your ablations are lesser. Number three, most likely, as you shown, this is a counterclockwise and atrial flutter, and that's the most common. The reason is that if you remember why the counterclockwise flutter is most common, another explanation I have is that if you look at the atrial anatomy from crista terminalis to the tragus valve is a native right atrium. Therefore, there's a lot of pectinated muscle. There's a fast conduction, sort of channels, if you will, and that take over. As soon as it impulse to exit out of crista, likely wise going to exit out first toward to the tragus valve side. Therefore, automatically set up the counterclockwise atrial flutter. If you look at the congenital cases overall series, every single map, almost invertibly, even in conference, that'll show you counterclockwise atrial flutter. That's why your P wave, flutter wave looks like that way. Okay? If you rotate it the other way around, as you said, it'll be positive and negative, not the negative positive. Make sense? Because you're going up and coming down. Yes.
Okay, so if we summarize the teaching point of Washington's very nice presentation, number one, before deciding CTI ablation case, you need to carefully watch the ECG, Holter, and associated structural heart, and atrial side, etc. And the second important point, if the patient has history of a previous surgical ablation, it is mandatory to review the surgical report or previous ablation report. So we need to check where the surgeons touch and where surgeons generated scar. And the previous surgery timing is also important. Before 1990, the many surgeons cannulated the pump through the right atriotomy, but now the surgeons became very smart and they try to reduce the scar as much as they can. So even not the congenital heart, there's an inevitable to incision the lateral wall scar in congenital heart surgery, for example, this kind of VSD surgery. But even in the valve surgery, mitral valve surgery, their incisional area is quite different, different surgeon to surgeon. So you need the timing of surgery and who conducted surgeon. It is also very important. And as Dr. Huang mentioned, high dense map, careful observation of high dense map can reduce your ablation regions. Dr. Wang.
May I comment one more thing quick, Dr. Wang, Dr. Bao?
Yes.
If you look at the Washington's map, there's a very critical point to a map is missing. Is that hole in the very superior aspect of your ablation line? The map, yes, there's no point in there. You should fill that up before you ablate, okay? That is a very important area that you should map complete. That's why it looks like a whole rotating map around there. Actually, it's not. It's a wrong map, okay? I recommend you guys.
Last comment is EP physicians should be perfectionist.
Yes. No, this is not an issue of perfection. It's the issue of where you have a very important area, your data is missing, and this 3D mapping gonna interpolate or extrapolate.
Yeah.
And you end up line maybe to get too short. This is critical because that's the area where you mid early, mid rat, late. So you should know definitely that's the end point, or can you go further? Okay? This is a very, very crucial area.
Thank you so much.
Okay.
Thank you.
Thank you so much.
레코딩 오프 하시고요.
Okay.
선생님, 탄자니아 어떠세요?
It's very hot, and I just moved to the it's what we call Serengeti.
Okay, I will start today's presentation. The patient is 36 years old female. She had a palpitation starting from 3 months ago. It was 1 or 2 times in 1 month. And the maximum duration was 9 minutes, and it showed the sudden onset and offset pattern. She was obese, BMI was 29. She doesn't have any past medical history, and his echo showed no abnormal sign. This is her chest X-ray. No cardiomegaly was noted, and this is 12-lead ECG, and this is normal sinus rhythm, and this is the outside filter, and this is the sinus rhythm, and we can see the premature beat without the compensator pulse, and so this BAC induced the narrow QRS tachycardia in here. And it goes on and it shows a sudden offset in here. So we started the EP study. This is the initial catheter positioning. Duodecal at the low RA and the CS, and the quadripolar at the his and RV. So this is the initial rhythm. The cycle length is 737, and AH was 81, HV was 53, and the QRS duration was 76. I think it was in normal. And when we did the RV pacing, we can see the 3 different types of the VA conduction in here. And in every case, the oldest A was noted in the history group, but this conduction and this conduction and this conduction show different morphology, and we checked the interval. The first one is 129, second was 125, and third one is 213. So it is about 80 millisecond difference. And after that, it conducted to this way. So when we see the continually, it conducted like this. And when we did the RV pacing of the 500 millisecond, we can see the ventricle echo followed by the VA conduction. And in the 450, there was a VA block cycle length. And again, we can see the this longer VA conduction pattern and the block and the shorter VA conduction in here. And when we did the single VA extra pacing, we can see the decremental property of the VA conduction. But when we did the progressed the single VA extra pacing, this was the VA conduction in 650 and 420, but the VA conduction was changed in the 650 and 400. It was changed spontaneously, and also there was a VA jump in the 380 and 360. It changed from 127 to 298, and it becomes ERP in 220, and we started the RA patient, and the AV block cycle length was 320. And when we did the single A extra stimulus pacing, AH was 134, HV was 55. It was similar to the baseline, and QRS duration was 77. And we did the 350. The H and HV was similar, but we can see the RBV pattern in the QRS morphology. And when it goes down to the 320, the AH was similar as the 138, but HV interval was prolonged to 161, and the QRS duration was 136 and changed to the LVV pattern. So we repeated this 600 and 320, and it again changed to the RB pattern, but HV interval was shortened to the 62, and QRS duration was 124. So this is RB pattern again. And when we goes down to 290, there was a HV block again, and there was no AV node capture in the 280 and 270. But in the 260, the AH interval was prolonged to 364, and we can see the normal HV interval and QRS duration. And 250, no AV node again. And in 240, the AH interval was 186, and we can see after activate in here. And then we can see the AH jump, it belonged to 302, and there is a sinus rhythm or PEC was noted with this, and there was AV node ERP in 220 and AERP at the 200. So we started the isoproteiner and started to induce the tachycardia. And with the isoproteiner 3 microgram per minute, the DAST induced the tachycardia. So after the DAST, there was no AH jump and the tachycardia was induced. And when we see the 12-lead ECG, it was similar pattern of the ECG in the outside quarter we saw earlier. And when we check the interval of the tachycardia, cycle length was 244, and the AH interval was 93, while the HA interval was 151, and the VA interval was 95. And so we started with the his refractory V pacing, and we go down to the about his refractory pacing, but it could not advance or reset the tachycardia. And we tried to do the ventricular overdrive pacing, but the VA conduction was not regular, and we could not entrain the tachycardia. And it also showed the self-termination, and it ends with V. And fortunately, the tachycardia was easily inducible with the DAEST. Again, it shows the tachycardia induction without the AH jump. And we did the ventricular overpacing with the V pacing of 270. and the A reading was continuously in here, but it was suddenly discontinued in here before the V captured the atrium. So the tachycardia was terminated with V pacing without the atrial reset. This is the timing of the atrial signal, but there was no capture before termination. And so in summary, the oldest day was his 3 or 4, so it is concentric pattern. There was a VA decremental property and VA jump during the SVST. And we also saw the age jump during the SAEST. And the narrow QRS tachycardia was induced, and it could be induced by DAT with isoproterenol. And we saw the VA interval was 95, AH was 93, and HA was 151. V reset was negative, and V pacing terminated the tachycardia without the A capture, A reset, and the self-termination with V. So we thought this was a dual AV nodal physiology and inducible AVNRT of the atypical type. So we placed the ablation catheter in the slow pathway position, and this was a slow pre-ablation signal. We can see the slow pathway signal in here, and we started the ablation, and there was a junctional rhythm during the ablation. And after that, we still see the age jump, but there was no induction of tachycardia or echo beat. So we ended the procedure with this. So age was 74, HV was 48, and respiration was 86. And this is the 12-day stage after the ablation. And one of the things I learned from this preparation, I started with the tachycardia termination with V pacing. And when the termination is in one paper I searched it, it classified the type 1 and type 2 termination after the V pacing. And when the termination is come after the atrial reset, technically termination with the atrial EGM interval change of the shorter than tachycardia cycle length, it could be either or orthodromic tachycardia or AV node reentrant tachycardia or AT, everything is possible. But in the type 2 termination, there was no atrial reset before the termination. That means no atrial ECM interval change before the tachycardia termination. The AT it prefers orthodromic tachycardia or AVNRT rather than AT. And this study also showed the result. There was about 200 cases in here. Although AT could be terminated with the type 1 termination, but none of the AT was terminated was VPC. And atypical or typical AVNRT or the ORT could be terminated with the this pacing or VA conduction was noted. So this is the end of my presentation, and thanks for your attention.
Matt, question?
So what do you think was the reason for that alternate RBB and LBB when you were doing echo pacing? Was it functional or was there a HPLC?
HB changed during RB.
Well, her baseline HG interval was normal, and there was no HV delay during the after the ablation. So I think this was a functional aberrancy of the nodal or infranodal conduction.
Can you show the intervals? What was the S1 and what was the S2? 600.
Yeah, 600, 360 was chart, and 350 was RBBB. 320 was the LBB pattern, and when we repeated it was the RBB pattern. And then no HV block in the 290. 280 no AV block, 270 no AV no. Then it came back with the long AH interval of 364 with the normal HV and the QRS duration. And then block again. And then we see the H jump in the 240 and 230. And then AV no DRP and the AER.
Can you explain the finding you show why during the straight VP thing,
Yeah.
V interval slightly change at the baseline EPS?
This,
Yeah.
I thought, but I thought this too was the retrograde pathway, and this was a slow pathway. Both the accelerated pathway retrograde conduction could be possible, but there was a decremental property, and the always A was always in the history and 4. So I thought it was a fast pathway and slow pathway.
But if you look at the right atrial signal,
Yeah.
so the first and second beat is opposite to third and fourth beat. CS activate the polarity is same. Only difference is the interval, right? I mean the right atrial side. H11 to 20.
Yeah.
And another the curiosity was the retrograde A activation sequence is quite different during the sustained tachycardia and echo beat. Did you see that?
So let's see the
You show the echo beat. This one,
yeah, this one.
and the tachycardia, right?
Yeah.
We interval is a little longer, and the activation sequence is a little different. So I think even though we ablated the slow pathway,
Yeah.
and with a diagnosis of atypical ABNLT,
Yeah.
but still we need to think about the other potential associated mechanism.
Such as excessive pathway.
Or Dr. Wang, we need your
Yes.
help interpretation.
Okay. Can we go to the very first slide, please?
Yeah.
The Holter tracing you show us. It's very interesting, actually. Okay, what do you see in the Holter? Tell me. No, Holter. Yes, this one.
Yeah, this one and this one.
Uh-huh.
This one.
Yeah, what is the first tracing? What it is? First 3-bit. What patient was in?
Sinus rhythm and the PAC.
No, patient in tachycardia 221. Okay, that is started. Narrow complex, 2P wave, like almost like a floater looking.
Channel 2 bar.
Okay. Yes. Yeah. There it is. Take a look. So you first PR is shorter. Second PR is longer. I think it is a collision of this. Not a PBC, it's aberrancy. I think you already showing us the tracing that this patient have an alternating bundle in this tachycardia. First is the right bundle. I mean, second one is probably left bundle. Back and forward is going, and tachycardia going. Tachycardia same, doesn't change anything. So patient in tachycardia already. Okay. The first thing I want to point out. And then patient warms up, become narrow complex, steady rhythm. That's probably what's been used. Agree? Anybody has any other question here? Different opinion? Okay.
Yeah.
So patient sustained tachycardia, narrow complex, and then suddenly conduction enhanced, and then whether PV is premature bleed, as you explained, I don't think it is. I think this is just the conduction, same conduction aberrancy, shortening narrow to the right bundle, and then get longer coupling. And then look at when you come left bundle, doesn't get pushed too much. So you need to measure those things. So when you're the right bundle, that subsequent R is shorter than when you're the left bundle, subsequent B. Or vice versa, I can tell which was the right bundle, left bundle, but is alternating. Okay? That's one implication you need to think about it. Next. Okay, go. The next slide, please.
Next slide.
Yeah, next slide.
I will go forward.
Okay, forward, yes, please. Go forward. Yes. So how old this patient was, you think?
33.
33.
Yeah.
So what is talking about this his bundle, EGM? So when you look at the HbO 53, okay?
Yeah.
And then his bundle, obviously not stable EGM, but his bundle duration is typically, if you record well, shouldn't be his bundle duration should be slightly short or narrower. This has a very complex EGM, his bundle. You got initial, especially second bit very clearly see, you can see activation sequence. Okay? Looks like a proper, but then look at the 3-4, channel 3-4, his bundle far field. Not right at the, what do you think about this EGM, his bundle? Kind of flat, and then looks like it's pretty noisy to me. But there's a potential. Precede the 1-2. Yeah, that guy. 3-4 channel. They just passed.
Next week, go.
Yeah, that one. Yes. You want to increase again on that thing, take a look at it, how long the his bundle conduction duration is. It's not normal. This person has a his bundle disease. Okay? That's why I'm asking this age. So, as I said before, EDP study, especially narrow complex tachycardia, you really want to pay attention to the HB channel. His bundle channel will tell you most of the time your answer. Okay? So let's think about this. If this patient has a disease bundle, can we have a tachycardia from disease bundle? That's one possibility. Second is we'll give you different pattern of a VA AV conduction as well, depending where the refractory is. So his bundle disease sometimes can complicate things a lot more than your usual tachycardia. So you start looking at those things. Okay? All right, let's go forward. Keep going. So this patient clearly has during the EOB pacing 600 millisecond. You have a progressive, alternating, or maybe unpredictably, whatever you call. And you can have a different VA conduction with the corresponding atrial activation sequence. Which certainly you could argue this is a dual nettle conduction going on. So then when you slow pathway exit through the more posterior CS, also you can have this pattern. Yes, it's possible. But unfortunately, I don't see his bundle conduction during the slow pathway conduction. Maybe into the QRS complex or outside, I cannot tell you. But I think this point of the study in the future, I would recommend you change his channel to the tight closed 2 millimeter catheter multi-electrode to see where is the true his bundle conduction is. Because this kind of case is very important. Matter of fact, this kind of case you can publish, you can write on paper. So I would put a 2 millimeter spacing catheter. But if you look at the third bit, channel 1-4 is obviously not validated that. Right after QRS, there's small notching, negative notching. Come to the right, a little bit more. After that line and cursor you draw. There, that's the his bundle, I think. I'm guessing. I cannot tell you sure. Okay? And then subsequent bit that disappeared, so I don't know where it is. So if we've seen that consistently, then we could argue, well, maybe there is a intra-Hisian conduction delay, okay? Promoting different ACT insert. So there's a theory long time ago when we study AV nodal conduction. My mentor told me, there's even AV nodal tissue, there is a destin fiber, one to the right bundle, one to the left bundle. They even that. So that's what we call it these days, upper common bundle. So I think it is something that think about it, but I'm not sure that's the case here. But go ahead, forward. Okay. So you basically, when you have a stable, it's basically the decremental VA conduction, you've proven that. But something that puzzles me time to time here, during the pacing, I want you to look at the heat channel 3-4 carefully now. And the first 2 bit heat channel 3-4. Do you see any tiny spiky? No, VA conduction. Right after first bit pacing. You don't see pacing. Yeah, that guy. And there's another noisy. And then if you look at the subsequent one, last one conduct longer, the timing change. You see that? The spike to spike. So I wonder, really, this is not a His bundle conduction disease related change that you've seen dominantly. Even though there's in top of that, there's a slow pattern conduction going on. That I think can make us to kind of confused. That would be a differential diagnosis here. Okay? AVNRT in the presence of a His bundle conduction disease. Therefore, anterolateral conduction pattern can change depending on the His bundle block is. Go to the right bundle, left bundle tracing that you had. Take a look. You had the one where they had the right bundle, the other one the left bundle. Remember that? Yeah.
Right bundle.
Yeah, one had the right bundle. I think you did extra stimulus something and then caused the right bundle, left bundle with some clinical tachycardia. Didn't you have it? Yes, this is the right bundle. Look at that spike, channel 3-4, where it is. Before that, first spike, my friend, come to the left. Yeah, no, you just passed it too fast. Come to the same bit again. Second bit, please. Come back. That guy, yes. And then second, his bundle is where? There. So do you believe that tiny spike is atrium? Or that's a far field A, or that's a his bundle? That's why we need a good ECG here. Otherwise, we're never able to answer this question. Okay? And then all the important question I'm going to ask you now, why the his bundle 1, 2, 3, 4 polarity reversed? If they're conducting same fiber. Shouldn't be. Should be same axis. Because if his bundle 1, 2 is R initially, his bundle 3, 4 is a Q. Very first component. Yeah, take a look, R, Q. That shouldn't be. There's something wrong here. That means maybe there is a conduction pattern of his bundle 3, 4 and 1, 2 is different. So when you read the paper by Anderson, he will just talk about the uncondensed AV nodal conduction. He talk about all this stuff, but that's all hypothetical, nothing proven. You're wondering whether this would be one of those his bundle disease case where you have an AV node is not completely organized, one single structure, multiple, then you can have a different pattern of conduction pattern, his bundle. Okay? All right, let's go forward. And they showed me the left bundle now. They show you on the right bundle. So it's beautiful. And HV interval shorter. Remember this here, okay? Your HV here shorter. When you have a left bundle, what happened? HV, complete different pattern, okay? And then now, what happened with that tiny, his bundle is probably not the same site, unfortunately. So now you have a septal A. Take a look at the septal A. Where is that septal A is? So you wonder, there is a long HV interval, right? In the channel 1, 2, his 1, 2. He says, far field A, and then that big spike, the his bundle, I think. Yeah, that's his bundle, I think. And then you got B, so that's a measure. But look at the channel 3, that noisy, where it is now. His 3, 4, 4, 2, 3, 4. Where is that spike thing? Way back there. No. Go further to the group B. Keep going to the right, coming to the right. Yeah. I think that's his bundle. That's that channel. So there's a dissociation between his distal and proximal. I think this would be done superb case report if you had a good tracing here. So it is important really to pay attention to what you're doing and take the time, because such unusual cases that really matters and teach us so many things that we don't know yet. And bottom line, what I think, if you ask me, for time being, my thought is probably this patient has, even the young age, unusual his-bundle conduction disease. And then you have a dissociation of a proximal distal his bundle and causing right bundle, left bundle HV interval variation. And second is that also cause dual nodal conduction tachycardia with different behavioral retrograde activations. Okay, that's what I think. So that's why Dr. Park's question is, why the atrial activation in AVNRT when you have tachycardia versus a slow atrial conduction and so on? That depends because your nodal input to this area is somewhat prefer one area to another. One going to almost posterolateral to the rightward is going to have that pattern of BA conduction retrogradely. But during the tachycardia, you go take a look at your tachycardia, sustained tachycardia before you ablate. You show us. Take a look. Keep going. Yeah, during the SVT, yeah, you create a tachycardia. Look at the activation pattern. That looks like more like when patient has slow atrial conduction, right? But in AVNRT, typically, even slow, you don't see this much. It's H13, 14, age very early. Do you see? Almost early proximal CS coming down at channel 13, 14. Channel 13, 14, VA conduct, yeah. V next with the A. That guy is almost same time with the CS. Yet, earliest is what? Subtle A. And there's a tiny spike in the front also of the onset of tachycardia. So if you look carefully, there is unusual notching signals changing. So I want you to follow that small spike, channel 3-4. Go to channel 3-4 now during the tachycardia. Come to the onset of tachycardia. Come back to the tachycardia. Right. You got that spike, okay? That's the first bit, right? Go to the next bit, second bit, second complex. That just before the QRS. Before. The two split, yeah, there's another one. And then your his bundle, distal potential changing as well. But if you come to the next one, yeah, there it is, right there. So you wonder, this tachycardia has a completely dissociated his channel 3-4, only sustained tachycardia channel 1-2. That means during the tachycardia, most likely prefer conduction through the distal his bundle portion. And then this proximal panel is probably bystander. Okay? It is a very, very interesting tracing, this actually. So I love to see this and sit down a little bit more, measure out these things. You can send me this case in email. I'll sit down and write all that stuff and send to you. Okay? Maybe we can write out a case. And you need to collect a little bit more about the patient data. Why this patient would have any risk factor for his bundle conduction disease. And I can explain you on that. Okay? Dr. Park, does it make any sense? What I told you?
Yeah, Dr. Wang, so excellent interpretation, and we learn a lot. But I have one question.
Yes, please.
Generally, if we pace A,
Yes.
his 3-4 is more proximal to atrium than his
That's
one.
correct.
How come his
Yes.
3-4, his potential is delayed, much more delayed than his 1-2?
I have one only explanation can I offer you. Okay.
Mhm.
I think this patient may have a retroaortic nodal tachycardia. That's what I think. If you ask me my honest opinion, impression right now. That's why you see so many high frequency spike in the proximal his H34, and then it's varying. The question is, this retroaortic nodal potential is bystander or is it part of tachycardia? Right now, I cannot tell you. I want you to read a paper published by Jack Scheinman and then Takashima, and they also, Japanese author. There is a persistent lapse of supravenous cava patient who has retroaortic AVNRT case report in Jack about, I think, 2-3 months ago. If you don't have, I'll send you article. Okay?
Yes, please.
They talk about this. Yeah, they talk about this. So we will have to discuss one day retroaortic nodal issue with the fellows because I think they need to know this. It's coming harder issue, and I think everybody interested in it. remember a long time ago I told you about there's a Takeoke paper about the superior slow pathway AVNRT cases. And if you look at read the article by the Wallens group, they don't think it is. It's a retrograde heading node tachycardia. So there's a lot of debate going to go on next few years about this. So I'll send you papers so you please read it. Okay.
Do they prove the AV node, not his bundle, is located in the retro aortic area?
No, this is a embryolotic tissue, primary ring of the node, the conduction system tissue that malform. They separate out from the AV node, connect through the small channel of fiber, like a pathway, almost like a pathway. So during the tachycardia, they can be part of a tachycardia source, which I think is Seoul National University case we did is the case. The other ones just have trigger activity and then AVNRT start. And some of them are, they are very close to each other, so they can say couldn't be 100% sure. Now, Mel Chapman's case, though, persistent supravena cava, your AV node anatomy is completely abnormally changed because of a presence of a persistent supravena cava. So I could not tell 100% sure, but they basically argument and they prove that that is probably such a case, and by pacing and many other things. But they did use a very beautiful small space his bundle catheter record these cases. Yeah, this would be probably we done that. You had a very clean tracing in channel 3-4. That would be superb case to see. Okay. Because I think what happened here, because you guys couldn't see that small potentials, the indicators are gained too much and noise contamination, hard to know what it is.
Yeah.
So I think we should do. Yeah.
Small potential. I thought completely 100% it is noisy, but
yes, but it is not noisy, my friend. This is a real case, I think. Okay.
Okay, so it might be very grateful if you send a paper.
Yeah, I will send it to you. Yeah, sure.
Seong also send the case. And
yes, please.
Helpful.
And the one day, I think afternoon, after EGM conference, we'll sit down with the fellows, go over this issue in the lecture, and then let's discuss it, because I think it's such an important issue, particularly when Rashim, other people go to third world country. They don't have much tool to do research, but I think at least tracing EGM cases, wonderful cases, I think you could still write up. And then you don't need the 3D to do that.
That's
okay?
Washim is already writing several of the case reporting papers. He's very active to writing.
Wonderful. Yes, wonderful. I love to review to see you guys writing that. Okay.
Okay. Thank you so much. And
thank you so much. Yes, please.
Okay. Thank you very much. Dr. Wang, please stay safe trip back.
Thank you. Okay. Bye now.
Very nice. Interesting. 저거 나한테 좀 보내주세요.
네,